starting this symposium, I'd like to extend my thanks to Lily. On top of the list is our friend, Professor Dr. Nabil Mubarak, who gave me this nice opportunity to be here. The symposium will be concerned with an important disease entity, a major health problem not only in our region but worldwide. We are dealing with 1.6 million cases of lung cancer a year and 1.3 million deaths from this disease. It carries a very high death rate. We'll start by the first speaker, a friend of mine and my colleague, Professor Ahmed Hamada, who is a professor of clinical oncology faculty of Medicine College University, and he is the director of NEMROC. NEMROC is Qasr Al Aini Center of Oncology and Nuclear Medicine. Please, Professor Ahmed.
Good afternoon, everybody, Mr. Chairperson, dear professors and colleagues. First, I would like to thank the Eli Lilly team and my dear friend, Professor Nabil Mubarak, who gave me the opportunity to be present here among you to discuss the first-line treatment for advanced non-small cell lung cancer. This is my disclosure slide. And as you know, with lung cancer, we have a magnitude of problem. And the problem lies that we have new cases, a lot of new cases, and the main problem is that approximately 40% of such new cases are stage 4 at presentation. And also the problem lies that we have a lot of deaths among these new cases, and these deaths, it approximately reaches 160,000 deaths in the year 2012 for lung cancer, which is comparable to all combined together prostate, pancreas, breast, and colon cancer. Also, the third problem, that still the 5-year relative survival rate as an overall is 15.7% and 3.7% for patients with distant stage disease. Concerning the histologic subtypes of non-small cell lung cancer, we have evidence that we have a decreasing incidence of a squamous cell subtype over time, and this according to the American Cancer Society database, which is available at the year 2014, where, as you see in the curve, the adenocarcinoma, the blue one, start to increase, while the yellow one, the squamous, start to decrease, and the large cell is still the same. And 85% of lung cancer are non-small cell lung cancer, 40% with adenocarcinoma, 25 to 30% with squamous cell carcinoma, and approximately 10 to 15% with large cell carcinoma, and the not otherwise specified constitutes approximately 20%. In order to evaluate, definitely we rely on chest CT scans or PET imaging to evaluate a lung lesion, and diagnosis confirmed definitely through pathologic evaluation of a biopsy, and the pathologic assessment after biopsy should provide some information concerning on the tumor histology and the molecular abnormalities that may be useful in selecting our therapy. And for advanced non-small cell lung cancer, the metastatic disease is automatically considered as stage 4, and patients with stage 3B often considered to have advanced non-small cell lung cancer, and they are not surgical candidates, although the tumor has not been metastasized. These are the American Joint Commission Cancer 6th edition and 7th edition. And the main difference that, yes, M1A is being malignant pleural or pericardial effusion, and M1B is distant metastasis. Also, you can see that T1 is subclassified to T1A and T1B, and also T2 to T2A and T2B, and these are the new 7th edition. So what about the prognostic factors in advanced non-small cell lung cancer? For patients with inoperable disease, the prognosis is adversely affected by mainly the performance status, the weight loss for more than 10%, and the sex, especially in males. However, advanced age alone has not been shown to influence influence the response or the survival with therapy, but may be associated with comorbidity that can limit our therapeutic options. Another considerations for first-line therapy, definitely other than performance status and age, should rely on the organ function, nutritional status, and the main symptoms of hemoptysis, if it is present or not, and then histologic subtypes, molecular variant, and the presence or absence of CNS metastasis. These are the treatment algorithms for advanced stage non-small cell lung cancer by the year 2014, where they propose definitely molecular pathway and a clinical pathway, mainly depending on the performance status. And concerning the molecular pathway, we depend since 2 or 3 years on just the EGFR mutation, but nowadays we introduce the ALK also. And for the performance status, we subdivide the patients into good performance status and poor performance status. And then came the role of histologic subtype, whether we have a non-squamous or a squamous. And for the poor performance status, we rely only on the single-agent chemotherapy. What about the case 1? We have a 46-year-old white female presents with persistent cough, with no hemoptysis, with 10 peg per year smoking history. However, she quit 18 years ago. He had a performance status of 90%. He had a PET-CT which revealed a 4.5 centimeter mass in the left upper lobe with multiple pulmonary and bony metastases. The FNA biopsy of the left upper lobe mass discloses a non-small cell lung cancer not otherwise specified. Only a few malignant cells have been identified in the cell block, but suggest a TTF1 positive adenocarcinoma, and her brain MRI is negative. The molecular subsets of lung cancer have been defined by driver mutation, mainly the EGFR and the KRAS, followed by the ALK. And still we have unknown consideration for such driver mutation in approximately 50% of the patients. The importance or the guidelines for molecular testing for both EGFR and ALK, that primary tumors and even the metastatic lesions are equally suitable, and the discordance between the mutation status of the primary tumor and the metastasis appear very rare. Molecular testing results should be available within 2 weeks of the specimen receipt, and pathological sample preparation using heavy metal fixatives or acid preparations compromise such molecular testing. These are the first-line treatment with EGFR TKIs versus chemotherapy in EGFR mutated patients, where we have a lot of trials starting either by gefetinib or Iressa versus carboplatin, and we have the erlotinib versus carboplatin Gemzar, and we have the ERTAC erlotinib versus platinum-based chemotherapy, and lastly the LAX-LANG3 afatinib versus cisplatin pemetrexate. They recruit a good number of patients, and they showed a median progression-free survival in favor of the target agents in EGFR mutated patients. However, the median overall survival was not statistically significant. And this has been shown by the IPASS, where the progression-free survival by EGFR mutation status. The IPASS is a randomized phase 3 trials previously for untreated patients with advanced non-small cell lung cancer, and they recruit approximately more than 1,200 patients, and EGFR mutation strongly predicts the progression-free survival to first-line gefetinib versus carboplatin, which means that if you have an EGFR mutation positive, you can treat your patient first by gefetinib, and this had a very good hazard ratio of 0.48 and a highly statistically significant p-value. While if you have a wide EGFR mutation or what is called negative EGFR mutation, you cannot start by target therapy and you should go for combination chemotherapy. Also, we have the LAX-3 and the LAX-6, who are first-line afatinib versus chemotherapy in patients with advanced EGFR mutation-positive non-small cell lung cancer. And in these 2 trials, we recruit more than 600 and 70 patients, and they randomized the patient 2-to-1 to oral afatinib, 40 milligram per day, or up to 6 cycles of the standard chemotherapy, pemetrexed cisplatin, and in LAX-3 and in LAX-6, gemcitabine cisplatin. Definitely, we have some improvement in the progression-free survival as a primary endpoint, 11.1 month in LAX-3 versus 6.9 month with statistically significant p-value, and also in the LAX-6 we have 11 month again versus 5.6 month chemotherapy. However, this study has examined the results of secondary endpoint, which is overall survival in each trial, plus an exploratory analysis of combined overall survival. And look at this, they showed definitely a statistically significant overall survival for each trial. However, when we go for the combined analysis for a 631 patient with EGFR mutation, the overall survival have been significantly improved with afatinib versus chemotherapy, with a median overall survival of 27.3 versus 24.3, which means a 3-month in favor of afatinib. Also, when we go for the deletions or some of the form of deletions that are present, the hazard ratios for deletion 19 was statistically significant, while for L858R was not statistically significant. So they conclude that yes, combined analysis of LAX-3 and 6 showed significant improvement in overall survival of patients with common EGFR mutation when treated with first-line afatinib, and prolonged overall survival with first-line afatinib versus chemotherapy in non-Asian patients with common EGFR mutation, especially the overall survival has been for deletion 19 mutation. And came the timeline for the ALK fusion in non-small cell lung cancer and the development of crizotinib since the year 2009, where it shows some anti-tumor activity in advanced cancer with AML4 ALK rearrangements. And going through the profile 1007, they showed definitely a progression-free survival in favor of crizotinib versus chemotherapy, 7.7 PFS versus 3 months, and also the time to patient symptom deterioration was in favor of crizotinib versus chemotherapy. This has been confirmed again in the profile 1014, where crizotinib versus pemetrexed platinum in advanced non-small cell lung cancer. Again, we have 11 months for crizotinib versus 7 months for the combination. Also, we have the alectinib, and it shows some improvement and efficacy in overall survival in some crizotinib-naive patients with ALK-positive non-small cell lung cancer. So the take-home message is that definitely obtaining adequate tumor tissue for histologic subtyping and molecular profiling should now be considered the standard of care. EGFR mutation and ALK is critical for making treatment decisions, and testing should be concurrent and completed within 2 to 4 weeks maximum to ensure timely initiation of therapy. And the first-line targeted therapy for patients with EGFR mutation or ALK fusion is now a standard of care. My second case is a 69-year-old female present with cough and dyspnea on exertion. She quit smoking 8 years later and is still working, but has a 40 pack per year exposure. The chest X-ray shows a 4 centimeter mass in the right upper lobe. CT confirms the mass and shows 3 liver lesions and a 3 centimeter left adrenal mass. Brain MRI negative. PET confirmed such lesion with no bone lesions. She had a performance status of 1 and past medical history of mild COPD. The most accessible lesion is the adrenal mass. 3 core biopsies have been obtained, and FNA for a cell block, and the pathology revealed TTF1 positive adenocarcinoma. She had a wild-type EGFR and KRAS negative for ALK translocation, and the patient desires definitely treatment. So histology in management of advanced stage non-oncogene-driven non-small cell lung cancer is very important. And as approximately 80% of our patients are not given the molecular driver mutation, we should go for the histology and we should answer the question, What is the current treatment algorithm in the absence of known or targetable oncogenic driver, and is still non-small cell lung cancer histologic subtype of prognostic value, and it is of predictive of differential benefit from available therapies? Definitely, these are the treatment considerations in absence of EGFR or ALK biomarkers, and we should choose the optimal chemotherapy, and we should not forget the role of targeted therapy, especially the anti-angiogenesis. The therapeutic plateau have been reached by the ECOG 1594, where we have carboplatin paclitaxel, cisplatinum gem, cisplatinum docetaxel, and carboplatin paclitaxel, and there was no clear efficacy benefit for non-platinum combination or triplet combination, so definitely we are in need of a new paradigm, and this was since the year 2002. And the ICOG 4599, where a phase 3 trial of bevacizumab in squamous non-small cell lung cancer, they randomized the patient to paclitaxel carboplatin versus paclitaxel carboplatin, and they add the bevacizumab, and they showed definitely through this a hazard ratio of 0.66 for the progression-free survival, and the hazard ratio also for the overall survival. While for the AVE and the GO19907, they recruit only a positive hazard ratio for PFS, but not reaching for overall survival. So yes, we can add anti-angiogenic therapy to chemotherapy, and this will add at least for the PFS. Concerning the toxicities, we have less toxicities with bevacizumab, especially for grade 3 adverse events, ranging for bleeding for 4%, hypertension for 7 to 9%. And coming to the phase 3 study where gemcitabine cisplatin versus pemetrexed cisplatin as first line, and they definitely recruit patients with advanced stage, previously untreated non-small cell lung cancer, a very large number, more than 1,725 patients, and they show an overall survival quite comparable of 10.3 months, but when they go and stratify the overall survival by histologic subtype, they go for non-squamous cell, a benefit of adding pemetrexed and gemcitabine with a median survival of 11.8 versus 10.4, and for the squamous, the controversy where cisplatinum gem is much better than cisplatinum pemetrexed. Also, passing through all the survival hazard ratio in groups according to baseline characteristics, we noticed that all age, performance status, bulk of disease, or cytologic diagnosis, adenocarcinoma, large cell carcinoma, all these favors the use of cisplatinum pemetrexed than favoring cisplatinum gemzar, and also the toxicity profile of cisplatinum pemetrexed is much better than the cisplatinum gemzar, so it is a safe and very tolerable combination chemotherapy. Going to the point break phase 3 study, where they randomized patient to pemetrexed carboplatin beva versus paclitaxel carboplatin bevacizumab, and then patient without disease progression, they were maintained to pemetrexed beva versus bevacizumab, and again they are quite comparable for overall survival, but still the pemetrexed carboplatin plus bevacizumab showed a median progression-free survival better than paclitaxel carboplatin beva, and the overall response rate is quite comparable, and the time to progression of disease was in favor of pemetrexed. However, the toxicity, when added to gemcitabine, we have more neuropathy or sensory neuropathy and alopecia more in the pemetrexed paclitaxel carbo, while we have some anemias and thrombocytopenia and neutropenia for the pemetrexed. The S130 study, where they use pemetrexed carboplatin versus bevacizumab paclitaxel carboplatin, is ongoing trial, and they will maintain the patient until progression of the disease with pemetrexed bevacizumab. For the squamous cell, we have an unmet for treating. However, nowadays the platinum doublet remains the standard of care, and the pemetrexed is no longer approved for use in this subset, and still we are waiting for new strategies in this large group of patients. We have the trial comparing carboplatin non-paclitaxel versus carboplatin paclitaxel, and it shows a very good response rate, 41% versus 24% in favor of the non-paclitaxel, and also the carboplatin for overall survival, they are quite comparable. Concerning the carboplatin and paclitaxel, when we add a PARP inhibitor, the Veriparib, we noticed that it works good in the squamous cell carcinoma concerning the PFS and overall survival, and even the overall response rate and the duration of overall response. So Veriparib definitely improved both PFS and overall survival, and this has been in the squamous histology subtype. However, definitely you are in need of phase 3 studies. So to conclude the standard of care in patients without identified driver mutation, our first line for non-squamous cell carcinoma is pemetrexate or taxane-based tablets for 4 cycles. And for the squamous, we have taxanes and gemcitabine-based chemotherapy for, again, 4 cycles. So my take-home message is that, yes, advanced non-small cell lung cancer is a prevalent and deadly cancer. First-line therapy, we have several chemotherapy and targeted therapy. The chosen is always by histology or mutational status. If you didn't have a mutational status, we think that cisplatin and pemetrexate should be one of the standard of care, and also the future direction and ongoing needs. Many patients do not respond or relapse on existing therapy, so promising agents under investigation, especially monoclonal antibodies and small molecule inhibitors of EGFR and VEGF pathways are ongoing, and thank you very much for your attention.
Thank you, Professor Matt, for your excellent presentation and overview of non-small cell lung cancer, advanced stage and metastatic non-small cell lung cancer. I do suggest and prefer to open the discussion now, not at the end, because the 2 subjects are totally different. Any questions for Professor Ahmed?
I'll start with the first question. If in case 1, which you said that you're going to do the oncogene driver, and you have to wait for 2 weeks would you wait for this patient? You will not start any treatment until you get the result, or you will?
No.
What will you do in your normal practice?
Yes, the recommendation is to wait from 2 to 4, and that you could start your chemotherapy definitely until the mutation came, the results.
Can I have a comment, please? Can I answer another?
Please.
The same.
Please.
A comment. Usually, this area is usually gray. The area of the waiting period, if you are not aware of the EGFR status of your patient, you can start by the standard of care in adenocarcinoma, let us say adenocarcinoma, and you may take in your pocket, if positive or if mutant, for maintenance, for second line if you wish, or we may add, according to the guidelines, we may interrupt the treatment and go directly to, it's according to your decision. You can interrupt your treatment. Let us say the patient received 1 cycle of alintacarb, let us say, then he was EGFR mutant positive or EGFR mutant. You can interrupt the chemotherapy and go directly to anti-EGFR. The question is, if you have a patient, non-small cell lung cancer, adenocarcinoma, EGFR mutant, you have the choice to give either afatinib or to give erlotinib, Tarceva or Gelotrif. What do you choose? What do you prefer? Do you have any data comparing both oral TKIs as first-line treatment? Yes, please.
It was a non-inferiority trial, and it proved to be equal, no difference. But for afatinib is now used for first line very recently, and still there are no data about afatinib as compared to the others.
I think I have a small comment. Yes, we have actually data from the Lung 8 comparing afatinib versus Tarceva up front, head-to-head comparison in second line. And there was a marginal benefit, very marginal benefit, favoring afatinib over Tarceva or over erlotinib, but with added toxicity. So up to this moment, as Professor Rabab said, we have no mature data comparing the afatinib versus erlotinib. But we have choices either to give this or that. I do prefer, because of the big experience or the huge experience with erlotinib, to start to my own point of view, to start with erlotinib. Another important question, if you allow me, what is the importance up to this moment of KRAS? As you mentioned, because KRAS carries the highest percentage among the mutation in non-small cell lung cancer, is approaching 25 or 23, 25%. Does KRAS has an importance in selection of treatment or not? Yes.
I think up till now, KRAS is not done routinely in lung cancer, although it carries a bad prognosis to the patients, and we know that when you have KRAS positive, the percentage of having GFR or ALK will be very low. But there are now new drugs for KRAS under investigation, which is the solumetinib, and solumetinib is used with docetaxel, and the results are very promising. Yes. So I think KRAS will be done afterwards.
So up to this moment, KRAS has no predictive value in non-small cell lung cancer. It does not predict the resistance to oral TKI. The only value of KRAS up to this moment is the prognosis. It is of prognostic and not of predictive value, unlike colon cancer. Another important issue, if you allow me, it's not the it's not the direct question, but it is avenue for discussion. Can you do, or you prefer to do, as you mentioned, the concurrent assay or the concurrent examination for EGFR and ALK both together? Because we have data that both together could be positive. What is meant by the coincidence rate? We have data, recent data, that there is coincidence rate. I can see a patient muted for EGFR and positive for the ALK in 5 to 13% according to the series. So we have to do it concurrently. And I don't know what to do if the patient is EGFR muted and ALK positive.
Yes, if it was positive, how to proceed?
But to my own, I don't know. But we have to do both together, not to wait. Yes, please, Dr. Abdulaziz.
Thanks for the excellent presentation, Professor Hamad. You insisted in both cases that the MRI for the brain is negative. Does the treatment will differ if the brain can metastasis?
The guidelines, yes. In early cases, we cannot go for MRI brain unless the patients will go for surgery. But for advanced stage, you should go for MRI brain as routine. Is it the answer? No, I will add in the line of management. I will add. If I have a positive and asymptomatic, I will proceed with what I do with chemotherapy. But if the patient is symptomatic, I can go for just palliative radiotherapy.
Yes, Professor Rabou.
I'm always confused about the relationship between pemetrexed and crizotinib. I heard and I read several times that there is a correlation related to the TS level, and so crizotinib may be more effective when you add pemetrexed, and maybe this is the cause when you have the ALK positivity or the ALK rearrangement. Pemetrexed was very near to crizotinib and very far from docetaxel. Docetaxel was low and pemetrexed was high. I want to know the correlation between